Okay, hey, thank you very much. We are hosting our Hill Venture Lab podcast. This is Jaemin Park from Hill Venture Lab. Here we have our good friend, the Secretary of Health, Dr. Ted Herbosa. Thank you for coming.
Thank you, Dr. Jaemin, for inviting me here in your blog. I hope we can inform the public about all the affairs in global health.
Okay. So, Sec, we have a pretty broad audience of course, public health, I guess, intellectuals, but also in other healthcare systems in different countries like Singapore, Thailand, Vietnam. So we're actually quite curious to, of course, cover your recent work with World Health Organization. But of course, I think we'll start from basic topics like your personal background, how you became the secretary, how's your day-to-day work like. And then, of course, after that, we kind of dive into, of course, we can go into many topics in UAC, but maybe we go into specifically what really happens in WHO and how that could also create impact for the, of course, Filipinos, but also the health system as a whole. So maybe we can start first with just a little bit about yourself, please.
Just a little bit about myself. You really wanted to be, I didn't want to be Secretary of Health. I wanted to be a Benedictine monk. And then my parents told me, no, you decide that after college. So I decided I can't be a healer of souls, I'll be a healer of the body. So I decided to take up pre-med at the University of the Philippines. There I already started to have leadership roles. I became an officer of the Pre-Medical Society, UP Pre-Medical Society. I eventually became president of the UP Pre-Medical Society. In med school, I was just tagging along. I realized having classmates that were magna cum laude, summa cum laude, put me in just the middle rank. But I stayed quiet in med school. But in residency, I again took leadership roles. I became chief resident of the Department of Surgery and became active in the foundation of the Philippine Society of Emergency Care Physicians, and eventually became its president, and eventually helped unite all emergency physicians in the country. This is two big organizations that were banging their heads, and I was able to broker a deal. And then I eventually got more leadership role because I was the youngest chair of a department in the Philippine General Hospital. All my professors were chairmen of their departments. For emergency medicine, I was the youngest and I was their student. So I learned a lot about governance, how the government works, how do you procure, how do you hire people in government. So everything I learned about government, I learned in the Philippine General Hospital. In fact, there was a time I was nominated twice for director of the hospital. The first time, I was instructed by the chancellor of UP to actually run as a rabbit. Because of that, I accepted a visiting professor position at the Universiti Kebangsaan, Malaysia, and exposed me to working there with another country, with another health system, more British than American. And then when I came back, I was again given another position that was leadership. I became Undersecretary of Health of Secretary Enrique Ona during the Pinoy administration, the Aquino presidency. And that's where I actually got oriented to how the public health system really worked, the Department of Health. So
very interesting career.
And at that time, we actually pushed for the implementation of universal health coverage through Taxation, which is now a case study globally. All countries are now studying how we were able to raise financing money to fund a health system to go towards universal health coverage. And luckily, when I came back today, even after that, when I stepped as Undersecretary, I got another leadership position, which was the Executive Vice President of the largest university in the Philippines,
UP.
University of the Philippines. At that point, my career path was not Secretary of Health. My career path was to become the first UP president from the medical field. So I wanted to be UP president as a medical professor. But again, I didn't get that. But eventually, I got shortlisted again as Secretary of Health in 2023 after the election. So, 2022, 2022 was the elections. I got the post 11 months later, 2023, June 5 of 2023. So when I came in, it wasn't welcome Secretary Ted, it was welcome back Secretary Ted. So everybody knew me in the Department of Health. So I hit the ground running. So I knew what had to be done. I knew what were the ills and the gaps in the healthcare system. So I started doing stuff, and that's where we are now.
So, I mean, you gave a very like a good from how you started, and then how you eventually came to where you are. Actually, we have also a lot of people, in our healthcare, like public health community, younger professionals and students, right? So actually, it's quite interesting that you recently started as a surgeon, but then you eventually went into public health. You worked at PGH, and then kind of got you to where you are. So, so at the time you were not thinking about public health.
How does the transition? Yeah. That transition is smooth because as a surgeon, I became a trauma surgeon. So I took care of emergency gunshot wounds, disasters. My interest was mass casualty incidents. So because of this, I became the chair of the Department of Emergency Medicine, the biggest emergency department in the country at that time. And that's where I started training emergency physicians as well. Because when I was training in Chicago, I saw the emergency physicians. We were part of the trauma team who were who could run trauma codes. So I said, this is probably what we need in my country too. So at that time, my view was the trauma system. And the trauma system, as you know, Jaemin, is the healthcare system. Basically, it's prevention, pre-hospital care, emergency room care, operative care, critical care, rehab. It's the whole continuum of healthcare system. So when you say, I'm only working on the health system, when I became undersecretary, it was a no-brainer because it's just the whole health system. Although my secretary then, Ona, was more focusing on cancer systems and non-communicable disease. But I didn't mind because a good trauma hospital will have the same facilities as a cancer hospital or an NCD hospital. If you're a heart, so at that time it was called heart, lung, kidney. It was called the Heart HLK project, the Heart, Lung, and Kidney Centers. So we designated heart, lung, kidney centers in different parts of the country. So that was the idea, improve the specialization and build it. So I used to say, what's your job as a trauma surgeon? And I said, as head of emergency, I consider my job to be the recipient of society's bad behavior. You drink, you drive, you crash, you're in my room. You have bad eating habits, you don't exercise, you get a heart attack, you're in my emergency room. You have hypertension, you don't control it, you don't take medicine, you also end up in my emergency. So my idea was, I'm the recipient of society's bad behavior. But I'm also the one that sees that the health system is failing. Because I would see people that should be treated in a primary care center. They have fever, they have just diarrhea, and they're going to the very busy emergency department. Why? Because the primary healthcare system had collapsed after the devolution. So I saw that the primary healthcare system was actually decimated after the decentralization and fragmentation of the healthcare system. Because in this country, Jaemin, in 1992, we passed what's called the Local Government Code. It gave autonomy to the local governments. So it's like a federal system. We gave district hospitals and provincial hospitals to governors to run them. And then we gave municipal mayors health centers. How the hell does municipal mayors and governors know how to run the health system? So what happened is we fragmented the then connected health system at 2 points. This was in 1992. And I was head of emergency in 1994. So eventually I saw this falter. The fact that we decimated primary care systems. It was working before, but they tried to make a fix that didn't fix it, made it worse. So now people use the ER as primary care.
Same with a lot of other countries.
Well, same as America.
Yes.
Same as America. So,
Yes.
so it was very clear to me because I'm talking to the solutions of emergency physicians in America was to fix also improve primary care. So they started doing ambulatory services. So what I developed, Bukas, is not unique. It's really the solution to this problem of being general hospital centric by creating this urgent care and ambulatory services closer to the communities. And it's a success. I mean, I only conceptualized building 28 urgent care and ambulatory service after I visited the Singapore Polyclinic model.
Yes.
I only promised 28 for the 28 million poorest by 2028. Now I have 63. And I think I have 5 more in the pipeline that's about to open. So it's a resounding success. People love it. It's also earning money because now I've pushed PhilHealth to push more primary care services in. So now even the private sector is interested to deliver primary care. So this is the game changer. The other thing I'm able to change with the current administration is now I've asked my regional directors, because the Bukas are run by my hospital chiefs who have residents in family and community medicine. I told the hospital chiefs, get your family and medicine residents out of the hospital and put them in the community. This is why the Bukas Center worked without larger tweaks in budget and anything. So it was just a tweaking of what was existing.
Yeah.
And then I asked my regional directors, people in the 17 regions in the country. I have DOH regional in charge of public health. I told before the concept was we stop at the region and ask the governor and the mayor to deliver primary and secondary health care. I said no, let's go down to so I'm actually doing it as a parallel. So I'm not violating any law because the law didn't tell me to stop at the regional. The law says we will support local government units that cannot develop primary care. So we developed Purok Kalusugan. We went Purok by Purok, and because the barangay health stations and the rural health units were run by municipal mayors, it didn't have anything. It didn't have doctors. It didn't have medicines. So my idea was to bring the medicines and the people straight to the community. So Purok Kalusugan is like a mobile mission that goes Purok by Purok. So suddenly the people like it also, and we have actually people commending the fact that they have a stroke, they're at home, they can't go to the health center, but someone from the health system visits them in the house. So this is again another game changer. So these two, Bukas, Purok Kalusugan, and then PhilHealth's emphasis on primary care actually helped a lot. And these are all game changers to the health system in the Philippines.
You're really, I think, filling the gap. You know, you talked about the devolution, of course, you know, and that's actually quite unique because if you look at Thailand or, I mean, Singapore is a small country, so obviously there's not going to be much about decentralization, but
they do. They have like 3.
Of course.
They decentralized to 3 corporations.
Yes.
They have 3 clusters, the East, the West, and the Central region. And they asked different companies, and then they made them compete with each other.
Yes.
So that's the idea. The national government worked on it like CEO of a holding company, and then you have 3 subsidiaries that run specific geographic regions.
So I think what we have in Philippines is quite unique. I mean, probably like a very, probably even more decentralized than, I mean, even maybe
that's
the level of
actually true.
Yeah.
So it's even more decentralized than Indonesia because the Puskesmas is under the Ministry of Health, the primary health care.
Right.
So ours was truly devolved, and that was where the difficulty was. The biggest difficulty of the decentralization was these health centers and these district hospitals were run by local leaders who were elected every 3 years. So can you imagine what happened? Every time they hired doctors and nurses, if there is a new mayor or a new governor, everybody gets fired.
Yes.
So eventually what happened was it didn't strengthen the health system at the local level. It weakened it because the doctors just resigned because there's no tenure, there's no security of tenure.
No continuity.
No continuity.
Yeah.
So they just went to the private sector, which created an access block. Access block, as you know, for emergency departments. They're there, but they're in the private sector. So the poor cannot access them. They only see a barangay health worker volunteer in the health center. So that denied access. That's what my Bukas and Purok Kalusugan did. Because we have like the National Health Workforce Support System. Nationally, we decentralize, yet we ask the national government to support local governments. I scratch my head because it's a paradox.
Yeah.
Why? We pay doctors a salary higher than the municipal mayor to work in municipalities. And then the mayor kind of gets envious with them. They get into all sorts of trouble. And then they pick up the corruption because they have to sign the procurement. And they see, why will I sign this? This is an overpriced paracetamol. So they refuse to sign it. They get death threats. So they come, we have to reassign them. So even these things are exposed to me because of our doctor. So I'm using the same doctors and rural health nurses to be part of the DOH to deliver primary care better. So it's like a parallel now. What I've converted is that the DOH is now like a big NGO providing grants to those that need them. If they're rich, why will I help them? Quezon City, Makati, they have good local health systems because they are well funded. But if the province or the municipality can't provide primary health care, we will step in and support you with national budget. But we also want to develop your local system. So we want you to have some continuity. So this is part of universal health coverage. So it's a parallel thing now. We support, it's like a partnership of national government and local government. So it's like a PPP, but it's national and local partnering. So that's my answer to that fragmentation of the health system. So it's no longer that fragmented. I've found a band-aid solution to actually go end-to-end, from strategy to delivery at the
you're
community.
really going down to the ground.
Correct.
So I think we can also do one episode sometime on this topic.
Of course, on local health systems, local health system development.
Today, I think we wanted to focus, I think more about like your day-to-day like experience as a secretary. How it's like when you start your day and then how it ends.
I'll tell
before
you
we
something.
go to the WHO and other topics.
You know, I think the brain is like a muscle. When I was about to retire as professor in emergency medicine and surgery, I was actually just teaching. So my private practice, I actually slowed down already. And I was ready to retire at 65. So I do rounds in the morning, probably some teaching during the day, do admin stuff. And then by 3 or 4, I'm already at home. I can conduct the whole ER from my phone, you know. I can give orders to my team and army. That was bad for my brain because it didn't exercise my brain. When I became Secretary of Health, I wake up at 5 a.m. I'm off the house by 6:30. I'm in my office by 7. I'm signing papers. I'm getting interviews from the radio. And I'm conducting meetings 1 hour after another. And these are hard meetings. These are high-level meetings. I'm attending cabinet meetings. My brain sharpened, Jaemin. It really sharpened. It was like it got exercised. I felt like the first-year resident again in surgery, wherein I have 10 tasks and I have to do all 10. I'm able to accomplish 7 or 8. So that's the exciting part. I now realize that even if you're old, if you really use your brain, you'll end up like a guy going to the gym every day. So my brain now functions like when I was young. I can remember everything. I can remember what I talked about with you in this meeting. Because I was like that when I was young. I didn't take notes so much. Everything was in my head. So my brain got sharpened. The other thing that I think was nice is now I have a bigger view of the big picture. I had a professor then, my mentor, Secretary Ona, and the former Chancellor, Alfredo Ramirez. Their tips to me about leadership is always look at the big picture. And that's where I am. I'm there at the top of the mountain with the president, the highest one on the health portfolio. But I see also what are discussed in economics, in defense, in natural resources, in energy. So I have I am conversational knowledge of how these things are talked about. Not what news you get in the press, but the actual data. When these experts present data to the president, I imbibe a lot of them. because I get to see how the analytics are done. So many of the things I know affect how I make decisions in the workplace. And then we get grilled in Congress, in Senate. You know, we have these legislators that, you know, interrogate us like we are criminals.
Well, that's their job. That's their job.
But there's job. There's their oversight job. But then you learn how to answer. You learn how to actually, you know what their objectives are. Some are very political, but some are real hard questions.
Yeah.
So I've learned a lot in the years that I've become Secretary of Health. I've learned about how the government works, what can and cannot work in terms of policy, what can and cannot work in terms of funds, because these are the things I'm realizing. I saw the budget of the healthcare system grow under this president. It's the largest ever, 448 billion. But I also saw throwing money at a problem doesn't solve it.
True.
Because you need some kind of efficiency, you need some kind of output. If it doesn't match, if the money doesn't match the problems, you end up with bigger problems, which is where we are. So I'm trying to solve asset management, procurement, things that are not medical. So with the medical side, I'm familiar with it. Medical and technical
of
stuff.
Course.
But delivering services, delivering goods, releasing information to the public, risk communication, these are the things that need greater emphasis.
You must have had a lot of things to learn. Remember when you first started, remember like the first week of your position as secretary, you had a lot of phone calls and you had to meet a lot of people. Like how was the learning curve? Like how was the experience for you?
Well, because I was a former undersecretary, I had a very short learning curve. In fact, I think I skipped my learning curve because I hit the ground running. In fact, when we were in the Senate or in Congress, there are questions. The protocol is some technical guy would write on an index card the answer and give it to me. By the time I get that index card, I had already answered, and it's the correct answer. So the people stopped writing it because they discovered I knew what the answers were. So, well, of course, if it's facts, then I really need to wait for the figure. But if it's about strategy, principle, philosophical approach, I'd be able to get it immediately. So that's how it was.
Okay. Hey, so Sec-Ted, thank you for explaining about your onboarding experience and your day-to-day experience as secretary. Maybe we'll just go cover two questions. I think very interesting question for the audience to hear, and then after that we go into the WHO. How was your what was your happiest day?
Happiest is when I became the first Filipino to be president of the World Health Assembly. So 194 member states of the World Health Organization. We meet every year in Geneva. So this is a meeting of all health ministers of the world. And I became health minister. Before, I used to attend the World Health Assembly, make a few statements, and then have some side meetings, and then it didn't bother. But as the presiding officer, I was listening to all the topics and all the statements. Because you had to, because you were there. And that made me grow again. I mean, I learned a lot of things. Things like, that was the time the US pulled out of the World Health Assembly, the WHO. And what my realization was that 80% of the member states are low middle income countries like the Philippines.
Yes.
And only 20%, the G20, is the rich.
Yes.
But for a long time, WHO was run by the G20. The heads of WHO, in fact, were actually what do you call this? But now, there's a big community of these low middle income countries that's searching for each other. And that's the type of response I got, that many of the LMICs are looking at what we're doing in the Philippines and seeing our success with taxation, primary care emphasis, specialty hospitals being built, and then struggling to give universal health coverage to 120 million people. That's not an easy task. And when and then there's health sector migration, because the other countries are pirating my very excellent health workers. So I just realized, number one, the reforms we're doing in the country are excellent because it's good for the Filipino people. Number two, I have soft power. I'm the largest exporter of expert nurses, medtechs, radtechs. But where did these guys train? They trained in a health system that made them one of the best in the world. So actually, they're my biggest ambassadors that my health system works. If I'm able to continue to produce these world-class nurses, they must be coming from a factory that produces good nursing care. So I converted my approach. I said, if you have a product that the whole world wants, do you stifle it or stop production? So my answer is increase production. If the world wants my nurses, I'm going to train more. And then I'm going to partner to actually let you train here. If you have senior nurses that want to train here so that they can learn what we do, we speak English, so they can all train here. So now I've opened it up. And now I have memorandum of agreements with Jamaica, with now with the other Caribbean countries, Barbados, Turks and Caicos, and also the South Pacific Islands. And then Singapore, Korea, all others are looking at us as leaders in health workforce development. Even this code of ethics for hiring, they look at us, the hiring countries, for our opinion. What I've done is what's called the South-South collaboration, meaning it's not about piracy itself. There must be some sort of win-win.
What do you mean by South-South collaboration?
So this is low middle-income countries helping each other. LMICs helping LMICs solve the problem of the global health workforce shortage. Do you know that we expect that there will be an 11 million person shortage for health workforce in the world by 2028? So that's huge. Philippines alone cannot answer that shortage.
True.
And if you let Philippines alone answer that, the health system in the Philippines will also collapse.
True.
But if I also ask all the nurses to come home, Singapore health system, the UAE will all collapse.
Of course.
Even the US may actually collapse if they don't have help. So there's the South-South collaboration removes that barrier of, headhunting, because countries like the UK, Canada, US, they hire the nurses with the highest salaries. Of course, people will be attracted to go. The best and the brightest will go to where the salary is and where the best option for their family is. So, to me, the way to actually counter that is to find a way to retain them, find a way for a circular return, so that some of the more senior ones will give back and train local younger nurses. Those that have worked in the US, in the Middle East, in Singapore would actually come back and train. So I call that the return migration or the circular economy, wherein I get highly trained nurses and medical allied health to actually go train more of the younger locals. So it becomes a win-win situation. Like now, I have tie-ups with Austria that hires nurses, but for each nurse they hire, they give back a scholarship for a young Filipino to finish nursing or some allied medical health. Germany gives me grants in terms of training biomedical engineers or biomedical technicians. So they support that. For others, Singapore recently will give master's program to my nurses so that I can have more teachers or faculty for nursing that can produce more nursing. So these are what I call win-win solutions, and these are the things I'm doing actually.
You get a view on how other countries are also positioning themselves for these kind of challenges. So it'd be interesting to hear also. Actually, we kind of jumped a bit, but how do you normally? What kind of topics do they normally talk about in WHO? What do you hear, and how do you navigate to get things done?
Okay.
Like you want to do a partnership.
So before, when I was still a young emergency doctor and we had disasters all over, in my field of disaster medicine, it was initially called international health. And somehow, that was the international health was the Johns Hopkins nomenclature for it. In fact, they had a master's for international health for emergency medicine doctors. Because of these conflicts around the world, outbreaks in Africa and all that stuff. So these are the people that came back and taught how health systems can be helped. But then it suddenly changed because Harvard, I think it was the UK who changed it to global health. I think the London School of Hygiene and Tropical Medicine. I don't recall now who, but it now became global health. After COVID-19, global health became very important because we saw in COVID-19 that no country was spared and that health systems should cooperate and work with each other. So this is the new global health architecture, wherein an outbreak in Africa can affect the Philippines. An outbreak in a ship like hantavirus can affect a country like the Philippines far away from the Atlantic Ocean. So, and then with global health, there's been a focus now less on disease, but more on health system strengthening, on being resilient, being prepared. Pandemic preparedness is talked about. International health regulations are talked about. So the global health stage became more important, even for the Philippines, because even the IOM, the International Organization of Migration, are also interested in the health of migrants. And we have 11 million migrants all over the world. So we're probably one of those with the big ones. So they learned from us what we have established. We created a department for migrant workers. We take care of our migrant workers in times of global crisis, where they are, whether they're in Africa or the Middle East. So our voice is very important. The Philippine voice is now very important in global health. The things we're doing in universal health coverage, the case story of sin taxation, or now it's called health taxation, taxing vices like cigarette smoking, alcohol, gambling. We've used all three for our healthcare system, and we're getting some success with it because we're not able to add additional taxes to people, but we're able to fund a comprehensive health system that is kind of acceptable, and we are lowering the out-of-pocket cost. So these are the discussions globally, and we need to be sitting in that table.
Right.
We cannot be an island in a global change. And even now, when we went to the World Health Assembly this year, the 79th, the 79th is talking about the new financial structure in a new global health architecture. So the funding that US used to give through USAID is all gone. So countries are struggling because I didn't realize that some ministries of health were fully funded by government agencies, like your taxes from America would be funding them. So now that's changing, and the approach is now how to become self-sustainable in terms of health. So examples like ours in the Philippines become very important examples for people to follow. When I was talking with some African health ministers, and I told them the story of the sin tax in one meeting in Abuja, they started talking about taxing mining for health, because that's what they have. They have lots of mining. So they saw the idea. It doesn't have to be the same concept as the Philippines, but the idea is that you don't have to tax the people to improve your health system. You can tax what you have. If they have a lot of diamonds or whatever precious metal, they can actually tax that and then put that to develop healthcare. So those are the different ideas that came out. And it's nice to be on a global stage because I also get ideas. So not only do we contribute with our solutions, we have talks of regional cooperation for vaccine production.
Right.
There is a shift. Vaccines are no longer produced by the Western world because they don't have children anymore.
True.
They're very true. There's no use for them to produce. But the vaccines are produced by India, Korea, but China.
Yeah.
Because we're the ones with still young people to actually vaccinate. So the markets are here in Asia. So you start to look at geopolitics and you start to realize healthcare goes with the geopolitics. Even this war now with Iran and the US and Israel, it's affecting us because although the medicines may not change, the cost of transporting them to the Philippines changes. Not only that, the dollar exchange rate, wherein the Philippine peso is crashing. That means even if the production cost is the same, The dollar exchange rate is now different, and I'm now everything imported. Imagine if I were producing those medicines here, the companies would profit more,
Right.
because paying peso to manufacture it is a
And sell
lower
it as a
rate,
dollar.
and then you sell it
Yes,
as
yes,
dollars.
of course.
So now I'm trying to attract these multinationals to invest in Philippines and actually produce, because that's the good side. Many people look at always just the bad side of things,
True,
but
true.
there's a good side of
Right.
of this lower price dollar. We become an ideal place to manufacture, because when you export, and then we have the free port zone. So you're a venture capitalist. You can get people to say, at 62 a dollar, you're already having profit by the time you sell that, and you're still paying your salaries in pesos. You're paying your energy in pesos. So actually, it's good for export market to have that weak peso, but it's also good for the OFW, because
Yeah.
the dollar remittances are in more pesos.
That's true.
So
true.
that's the other side. So but it's bad for us, because my gasoline price is good, my goods are more expensive. I'll probably be able to buy less medicines with the same budget they gave me a couple of years back, because that's the budget I'm using now. It was planned in a time when 57 to a dollar. Today it's 62.
So going into we covered about the manpower issues. Of course, a big elephant in the room in the global stage is financing issues. It seems
Yes.
like everybody is trying to come up with different ways to finance.
It's
And
health
of course,
economics and health
attracting
financing.
investment as well, right?
Yeah.
How do you you were in Geneva recently. So how do you prioritize I guess these meetings for
okay.
investment? What kind of particular investment are you looking for?
Okay.
And of course, and how long do this obviously cannot happen overnight, right? So what's the process to get it done? Yeah.
Very, very good question. So since I've been health secretary, this is my 23, 24, 25, my third. This is my third, right? My third World Health Assembly. And what has happened is that we've started connections during the first. And I just continued that. For this year, I had like 50 meetings
Yes.
in 5 days.
Wow.
So that's like 10 meetings a day.
Wow.
I had 2 MOUs. I rejected 33 requests for meeting me.
Why?
Yeah, because these were new meetings. These were
But these are all
meet
like
and
a
greet.
country to country.
Yeah,
Right?
minister to minister. It's
How do you
always
reject them? Like how do you prioritize?
Well, some I didn't reject. Some I could reassign to an undersecretary.
Okay,
Because I had a couple of undersecretaries and one assistant secretary with me. So I could delegate some. For some, I met them because they were continuing or they were promising projects. So I can name, for example, my meetings with the United Arab Emirates Minister of Health, because she had a very interesting take on how we can help Filipinos in the United Arab Emirates get continuous care when they develop catastrophic illness like cancer or stroke, because their employment stops, their insurance stops. So, but their insurance with the Philippine health insurance continues. So we're now talking of ways to be able to
to
provide
spend
them
over there.
yeah,
Wow.
to have
Okay.
transportability, and she's amenable to tying up insurance to insurance, so that we can cover these things. So this is useful for the Filipinos.
Of course.
This is not useful for me. This is useful to Filipinos and their families who are abroad. Another interesting thing is my tie-up with the Singapore Health Minister. We signed an MOU. They want to train and give master's scholarship to us. The other one is Korea. Korea, we signed a cooperation agreement, and Korea is donating a lot of stuff for me for TB diagnostics, for infectious disease, tropical disease. They're also helping me with health financing, HERA, so that PhilHealth can become better, just like the Korean health insurance system and their reimbursement, and computerization, digital health, because most of the hospitals in Korea are very, very digital.
Yes.
With the products like Samsung and all these computer companies in Korea. So these are the things that are helping me. I've also met with new ones like Barbados, who's interested in a tie-up and exchange for nursing. I've also met with Global Fund because now the Philippines is the principal recipient of Global. It used to pass through an NGO. In this new grant cycle 8, the DOH will be the principal recipient for TB and HIV. For malaria, it's still going to be, I think, Filipina Shell continued. So that way, I can give them tax-free donation because they were asking for tax-free. I cannot give you tax-free because you give your money to private organizations.
So before they will go through NGO.
Straight to the private.
And then, and now you're trying to go direct.
They'll now go direct to the government. Wow. So I'll get those same people as sub-recipients. So then I can give them their tax-free for their donation.
It'd be a good incentive.
So it's a good incentive. But it's also a transition to getting out of the Global Fund. Because I think this may be the last global cycle, grant cycle 8, maybe a grant cycle 9. But my goal is to stop after grant cycle 8. That means institutionalize TB and HIV into our TB Council and our Philippine National AIDS Council. So that way, we're able to institutionalize our own care for these particular diseases. I also met with the Pandemic Fund. They're giving me like $25 million. So you see, the amount of money I spent to bring a delegation of 15 is about 5 million pesos. But the amount of money I'm getting in return from all this tie-up is so much more.
There's a big ROI.
25 million. And these are grants. These are not like loans. These are grants given to me from the other countries that I just have face-to-face meetings in. So people don't understand that. They think I go there, I'm having a nice time eating chocolates and having fondue. But I'm not. I'm working from...
Of course.
If you've seen my schedule, I wake up, I start at 7, and I'm meeting everyone at every hour. And it's the whole Geneva. So you have to move from one hotel to another for meetings. So it's hard work because I worked with WHO before. I worked with the USAID before. So I knew how these things work. And that was my idea of bringing a lot of young people because I wanted the young people to learn global health and how the negotiations are, what the discussions are. I'm actually, by the 3rd World Health Assembly, I'm actually very happy because I'm hearing their interventions and their interventions are now spot on. When I was undersecretary, I was laughing at the intervention I was going to read because it wasn't well researched, it wasn't well done. Now I'm seeing better because they attend, they listen, they know the jargon, they know what are the issues.
Oh, the young people.
The young people.
Okay.
So the benefit of bringing young people there is like bringing athletes to an Olympics. They may not win the medals, but eventually I'm training the next generation in global health. And already, I can see some people making friends. I told them, go around, talk to people just like me. I talk to other ministers of health. You talk to the other technical people.
Who can potentially become their colleagues in the future.
Their colleagues, who might become ministers of health in the future. So eventually, you're up there. Some are pirated though. That's the problem with the Filipinos. I bring people and then eventually they're pirated by the international development partners because of higher salary. So, but that's a risk. I mean, to me, that's still not a loss. That's still a gain.
Of course.
When a Filipino starts working for an international development partner, that's a gain for the Philippines. That's never a loss.
They also gain experience over there.
They gain experience and they will continue because Filipinos are that way. They will continue to help the Philippines. The top HIV person in WHO was sent to me to help me. She's Filipina and she loves working here back. So there are things that return. And then the goodwill I have for talking to people, I'm hosting 2 events this year. The first event in September, the 3rd high-level dialogue on sustainable financing for non-communicable diseases and mental health. It's sponsored by WHO, the Philippines, and Asian Development Bank. All the high-level people will come here to talk about how we can finance NCD. The second one is in November. It's, what do you call this? The second global ministerial meeting to end violence against children. I'm also sitting as one of the 10 ministers of health declared as champions of ending violence against children. So I'm in a unique position because I'm 10 I'm in a council of 10 from 194 ministers that are championing ending violence against children. And the Philippines is it's a big problem. Sexual violence, cyber violence on young children is happening in the Philippines. We've done a lot. That's why we're in that council. But it hasn't stopped. So we need to continue our work. And this is a good opportunity because these things are not addressed very well. So this voice is very important. And it needs a global approach. Because...
WHO obviously is a very complex organization. And you are, I guess, taking a leadership role in the WHO.
Yes.
So what kind of functions do you play in the big WHO organization?
So even before I became World Health Assembly President, I was working in the region. We led what's called the Philippine Pacific Health Initiative, which is a way to bring the health system closer to our Pacific neighbors. And we put in money for this. So it's not just talk. We put in money, and we've sent teams now to Federated States of Micronesia, to Tonga, and our services and expertise are now being felt by these countries. And more countries are lining up to actually get that. In return, we're getting their patients to come here for highly specialized care. So although they go to the private hospitals, that's still revenue for the Philippines in terms of attracting them to get highly specialized healthcare that they can never get in their own island countries. The other thing is, I got nominated to be chair of the board of the Stop TB Global Partnership. So I replaced the Minister of Health of India, and I'm still sitting there as the chair of the board that gets all the funds coming for TB. So I run the board, and we actually hosted a board meeting last year here in Manila. And they said it was the best board meeting ever. So I get praised for that, for my leadership role in this. They also made me president of the World International Vaccine Institute. This is the collaboration of the private sector and many countries. So I'm president of what's called the Global Advisory Council of the IVI. So there are several member states that I'm the president, and that is also very important to me because vaccination and immunization and the development of new vaccines is critical for public health. We also got the vice chair of the program coordinating board of the UNAIDS. And that's because we're trying to get help for our HIV incidence, which is very high. Our prevalence is low, but our incidence is high. So with that, we got to sit at... But when we became vice chair, I didn't realize I will be the chair next year. So these are the things that we're getting. A lot of... And then the Council of Champions, I told you, I became Council of Champions. And many more. I'm also sitting in the board of the Pandemic Board, which is the World Bank and WHO thing. But I ended that already. May 31 was my 2-year term. So we got grants and provided grants to countries for pandemic, for increasing their resiliency and capacity. I'm also part of what do you call this, other health groups that set up. So the leadership roles keep coming just because of your presence in World Health Assembly meetings, because they know who you are, they know your ideas, they know how you think. You get offered all of this.
So being a minister doesn't automatically give you these kind of roles, right?
No.
You have to also navigate.
Perform,
Okay.
It's like in the Olympics, you like the athletes that are world record holders and those that are able to perform. So when they see your capability, you get this invite. So that connects with each other. So it's not an automatic thing just because no other health minister in the Philippines got the items that I was able to take home. What I've realized is now we've attained a level of respect from all countries about our healthcare system. I never felt that before. We've always felt that we come from a country that can't even fix its health system. Suddenly, they're looking at me, the Secretary of Health, and they're, telling me his leadership is good. And so when they praise me, the health secretary of this country, they're praising the health system of this country. So to me, that's the biggest. And that increases the value of nurses going abroad. In fact, I will fight for higher salaries for our nurses. if the higher salaries, that's how this global presence can be felt. It's a little bit off the mindset of how previous health secretaries thought. But I'm thinking global. But I act local.
Of course.
But I think global. So I think that's the new effort there. If you think global, your local actions will also be on point. On point.
That's your challenge. You have to, I guess, tie what's happening globally and also show progress here, right? So, we just go into a bit like a detail on let's say you have a partnership with an international organization and they want to give you a grant or funding. How is the process like? I mean, because, they're obviously not going to give you funding overnight or like over a week. So what's the typical process?
So it's a long process. I'm glad you're asking that question because it's actually a long process. Just last night, somebody was donating to the FDA, Starlink. But I described to them the process because they're a foreign agency. They have to first give that letter of intent to donate. I'll pass it off to the DF Foreign Affairs because it's coming from an and then the Foreign Affairs will pass it on to the Department of Finance. The Department of Finance will pass it on that letter to the Executive Secretary who will try to get from the Office of the President an authorization for me to receive that grant. So this whole process will take something like 3 to 6 months, sometimes longer if there are other critical issues. So that's because of a circular that says any international grant has to be approved by the President. For other grants, let's say soft loans or other co-investments, it goes through the Economic Development Council, and that goes through first a technical board, and then a sub-cabinet cluster, and then a cabinet cluster, and then the Office of the President. So it also takes about a year to get big grants. So there's a lot of work done because it goes through the economies at every level.
Even at the global, I mean, even before reaching here, even overseas, you probably also have some kind of selection process over there before these institutions want to award grant.
Correct. For example, I took a soft loan called the Health Systems Resiliency Project, funded by the World Bank for $400 million for 4 years. To work on that grant, I had to be the one to eventually present in the technical group to show that building health centers in remote, geographically isolated and disadvantaged areas will strengthen the health system. So when I was able to discuss that, it went smoothly upwards all the way to approval at the level of the President. So you can get that without working. And I'm knowledgeable about all of that because I've gotten a Spanish grant for the Philippine General Hospital worth $10 million. So I was able to do this even before when I was younger. So I knew all this process and I knew where to go. Then I've also gotten public-private partnerships, PPPs for solar panels, dialysis centers, and all that stuff. So we continue to go on all modes of financing, whether it's PPP, procurement, soft loan, or grants. We continue to have that. I'm very lucky. The U.S. continues to look at the Philippines as a close ally, and most of the U.S. aid grants U.S. aid was abolished, but I still got the money back for TB, for global health security, and more. So I think I got some of those that were from the other countries that weren't working. So plus there's increase of interest by Korea, by Japan, because I have my bilateral agreements with these countries that want to support me.
Thank you. So I think we're at the end of the episode. Maybe just one last question is, how do you want average Filipinos, I mean, because all the initiatives and hard work you're doing, it's not easy for them to see this, right? Yeah. So what do you want to do to help them see this, and of course, I guess, of course this would be like showing more improvement at the local health systems, etc. But what do you see on this? Like, how do you want to get them to see this better?
Yeah, so the problems most Filipinos encounter in the health system is not by me. It's run by the local health systems, by the mayor and by the governor. We are able to direct healthcare and steer these local chief executives to become better. So the way I would simplify is fix your problems. Those problems can be fixed. I'll look for the money. The money doesn't come internally only. It comes also internationally. So having that foot in the global health stage makes this flow of money come. When I had problems with TB drugs, Stop TB Global Partnerships gave me the drugs, the first line drugs to actually use. So that was a local problem, procurement problem in the local governance. But I was able to ask help from assistance. I ran out of diphtheria, tetanus toxin, diphtheria toxin. And I just asked the WHO people for it, and they gave me back the grant. So these are things that return back to me because they know who I am and they are willing to help. So I'm able to tap sources and solutions that other people can tap. ADB, World Bank, all these multilateral banks, COICA, JICA, US Global Health Security. They're all helping the health system in the country. People don't see that, but with that help, we spend less of our own tax money on the health system because we're able to use international support. So global health is an important part of building health systems. And for other countries, it's also an important way to get more assistance in building their health system.
They're all doing this just like you.
Yeah, all the ministers are doing this, and they're all there. They're all present.
Of course. Okay. Hi. I really want to thank you today for giving your insights. Taking your time to explain this. Despite your busy schedule, and of course, I want to thank our podcast audience and of course people outside for listening to the talk. And so, thank you for coming. I would like to interview you again sometime.
Yeah, sure. Thank you very much.